Imagine a healthcare system that promises protection for all, yet leaves a vulnerable population behind. In the UK, adults with learning disabilities are being systematically overlooked when it comes to cancer screenings. This isn't just a statistic, it's a question of equity, justice, and human dignity. How can a society claim to provide universal health care when some of its citizens are effectively invisible in the eyes of preventive medicine? The reasons behind this disparity are complex, yet deeply concerning. Many adults with learning disabilities face barriers that go beyond simple access. Communication challenges, unfamiliar medical procedures, and fear of hospitals or medical equipment can deter participation. Standard invitation letters and appointment reminders assume literacy, comprehension, and confidence that some patients simply do not possess. Additionally, healthcare providers may lack specialized training to accommodate patients' needs, resulting in environments that feel intimidating or unwelcoming. In practice, this creates a system in which one of the most vulnerable groups is less likely to receive potentially life-saving screenings. Here's the hook. The consequences are severe and preventable. Cancer detected early is far more treatable, yet people with learning disabilities are disproportionately diagnosed at later stages. It is not a question of biology or increased susceptibility. It is a systemic failure. The very structures designed to protect health inadvertently reinforce inequality, highlighting a gap between policy promises and lived reality. Social support networks, caregivers, and families often act as intermediaries, but they cannot fully substitute for a healthcare system designed to be inclusive from the start. Moreover, this issue reflects a broader societal assumption that adults with learning disabilities are less likely to benefit from preventive care or that their quality of life somehow diminishes the urgency of intervention. This is both ethically and medically indefensible. Healthcare equity demands proactive adjustments, easy-to-read materials, patient advocates, flexible appointment procedures, and trained staff who can navigate diverse needs with empathy and professionalism. Without such measures, the system continues to perpetuate disparities, turning a potentially simple preventive intervention into a life-or-death issue for those already marginalized. Addressing this gap is not merely a matter of healthcare policy, it is a moral imperative. Adults with learning disabilities deserve the same opportunity for early cancer detection, the same dignity in medical treatment, and the same protection against preventable disease as anyone else. Failing to ensure equitable access is not only a medical oversight, it is a societal failure. The question we must ask ourselves is simple. If a system cannot care for its most vulnerable, can it truly claim to serve all? Systemic exclusion in cancer. Screening adults with learning disabilities in the UK face a form of systemic exclusion that extends across multiple dimensions of healthcare, and cancer screening is one of the most stark examples. Despite policies that purport to provide universal access, the reality is that this population encounters barriers that effectively prevent participation in preventive services. Invitations for screenings, whether by mail or digital communication, often assume a level of literacy, comprehension, and familiarity with healthcare procedures that many individuals with learning disabilities may not possess. This disconnect between the design of healthcare outreach and the capabilities of the intended recipients creates an initial obstacle that significantly reduces uptake. In addition, scheduling systems and clinic environments are typically standardized for the general population, failing to accommodate the needs of those who may require additional guidance, longer consultation times, or familiar support persons during appointments. Healthcare professionals themselves are often ill-prepared to address these challenges, either due to insufficient training in working with patients with learning disabilities or the pressures of a system that prioritizes efficiency over inclusivity. Staff may inadvertently convey impatience or frustration, or fail to provide explanations in accessible language, further discouraging participation. Beyond the clinic, logistical factors such as transportation, navigating complex hospital layouts, and coordinating with caregivers add another layer of difficulty. Each of these elements contributes cumulatively to an environment in which adults with learning disabilities are effectively marginalized, not because of any personal choice, but because the system fails to meet them where they are. The structural design of preventive services also reflects implicit assumptions about patient capability and compliance. Standardized reminder letters, Automated phone calls and online booking systems are convenient for the general population, but can be exclusionary for individuals with cognitive or communication challenges. Without modifications, these systems fail to engage the very people they are intended to protect. Caregivers and family members often play a crucial intermediary role, but reliance on informal networks cannot compensate for the absence of systematic adaptations within healthcare delivery. The result is a persistent gap in access that is neither accidental nor unavoidable. It is the outcome of institutional processes that do not integrate inclusivity into the core design of preventive care programs. This systemic exclusion illustrates a broader principle. Equitable healthcare requires intentional design that accounts for the diversity of patient needs. When adults with learning disabilities are overlooked in cancer screening programs, it reflects a failure not of individual effort, but of structural planning, policy implementation, and professional preparedness, highlighting the urgent need for reforms that embed accessibility and inclusivity into every level of preventive healthcare delivery. The barriers preventing adults with learning disabilities from participating in cancer screening extend well beyond issues of physical access, encompassing a complex interplay of communication, comprehension, and psychological factors. Standard screening invitations often assume literacy, cognitive processing abilities, and familiarity with medical systems that many adults with learning disabilities may not possess. Letters and digital communications, which constitute the primary method of outreach, can be confusing or overwhelming, leading to missed appointments or complete disengagement from preventive care. Even when individuals are aware of the need for screening, the medical procedures themselves, ranging from mammograms to colonoscopies, can be intimidating. The unfamiliar environment, specialized equipment, and invasive nature of many screening procedures can provoke anxiety, fear, or outright refusal, creating an additional, non-physical barrier to participation. Healthcare professionals play a central role in either mitigating or exacerbating these barriers. In many cases, clinicians lack training in communicating effectively with patients who have learning disabilities, failing to adjust their explanations, tone, or pacing to meet individual needs. Appointments are often brief, highly procedural, and structured around efficiency, leaving little room for patient-centered dialogue or reassurance. Without staff who can provide patient advocacy, tailored guidance, or additional emotional support, adults with learning disabilities may feel excluded, misunderstood, or unsafe in clinical settings. This deficit in professional preparedness transforms what should be a routine, preventive measure into a source of stress, thereby discouraging ongoing engagement with the healthcare system. The role of caregivers and support networks is also significant but insufficient to address the systemic gaps. Families, social workers, and advocacy organizations often act as intermediaries, translating medical information and accompanying individuals to appointments. However, relying on informal networks introduces variability in access and consistency, as not all adults with learning disabilities have robust support systems. Furthermore, the absence of formal accommodations and standard processes places an undue burden on caregivers who must navigate bureaucratic procedures and advocate persistently for care that should be universally accessible. These barriers highlight a broader structural issue. The healthcare system is designed with assumptions that do not reflect the diverse needs of the population. Procedures, communications, and clinical practices are optimized for individuals who can independently navigate complex systems, leaving adults with learning disabilities disproportionately excluded. Overcoming these challenges requires deliberate adaptation, including simplified communication, patient advocacy services, flexible appointment structures, and professional training focused on inclusivity. Without these measures, fear, confusion, and systemic rigidity continue to prevent participation, perpetuating inequities in preventive healthcare and contributing to disparities in cancer detection and outcomes. The consequences of delayed or missed cancer screenings for adults with learning disabilities are both severe and entirely preventable, highlighting a critical failure in the healthcare system. Early detection of cancer is widely recognized as a cornerstone of effective treatment, significantly improving survival rates and reducing the complexity and cost of medical interventions. However, adults with learning disabilities are disproportionately diagnosed at later stages, often when symptoms have advanced and treatment options are more invasive, less effective, and associated with greater physical and emotional burden. This disparity is not attributable to biological predisposition, but to systemic obstacles that prevent timely access to screening services, revealing a structural inequity that undermines the principle of equitable health care. The life-threatening consequences of these barriers are compounded by a lack of tailored preventive strategies within existing health systems. Standardized screening protocols designed for the general population fail to account for the unique cognitive, emotional, and logistical challenges faced by adults with learning disabilities. As a result, opportunities for early intervention are frequently missed, and individuals enter treatment pathways at points where prognosis is significantly compromised. This delayed detection perpetuates a cycle in which a population that is already vulnerable experiences preventable morbidity and mortality, underscoring the ethical implications of systemic neglect. Additionally, late-stage diagnoses place an increased strain on both patients and caregivers, as well as on healthcare services themselves. Complex treatments, prolonged hospital stays, and intensive support requirements become necessary when cancer is detected at an advanced stage, creating challenges that could have been mitigated through accessible and inclusive screening programs. The societal cost, both in human suffering and economic expenditure, far exceeds what would be required to implement proactive measures to ensure equitable participation in preventive care. This imbalance reflects a misalignment between healthcare priorities and the ethical responsibility to protect the health of all citizens, particularly those at heightened risk due to systemic exclusion. Underlying these consequences is a troubling assumption within healthcare policy and practice that adults with learning disabilities are less capable of benefiting from preventive care, or that their reduced participation is an acceptable outcome. Such assumptions are both medically and ethically indefensible, as they effectively devalue the lives of a vulnerable population. Addressing these preventable consequences requires a deliberate restructuring of healthcare delivery, including personalized outreach, accessible information, caregiver integration, and professional training. Only by acknowledging and actively mitigating the barriers that lead to late-stage diagnoses can the healthcare system ensure that adults with learning disabilities receive the same opportunity for early detection and life-saving treatment as any other member of society. The systemic neglect of adults with learning disabilities in cancer screening programs reflects deeper societal and institutional assumptions that shape both policy and practice. One pervasive assumption is that individuals with learning disabilities are inherently less capable of benefiting from preventive health care, or that their quality of life renders early detection less urgent. This bias is rarely explicit, but it is embedded in the design of healthcare services, from the language used in patient communications to the standardization of procedures that assume comprehension and autonomy. These assumptions influence decision-making at multiple levels, from national screening guidelines to the behavior of individual practitioners, creating an environment in which exclusion becomes normalized rather than challenged. Institutional practices further reinforce these assumptions. Standardized invitation letters, automated reminders, and rigid scheduling procedures presuppose that patients can navigate complex administrative systems independently, an expectation that does not align with the needs of many adults with learning disabilities. When healthcare staff are not trained to recognize and accommodate diverse cognitive and communication needs, the clinical environment becomes unintentionally hostile, discouraging participation and reinforcing the perception that this population is difficult to serve. In this context, marginalization is not simply the result of individual oversight, but the product of structural design that fails to integrate inclusivity as a foundational principle. Social attitudes also play a role in perpetuating disparities. Implicit beliefs about dependency, capacity, and societal value shape both policy priorities and public perception, often rendering the health needs of adults with learning disabilities invisible. Policymakers may underestimate the importance of targeted interventions, while healthcare providers may unconsciously deprioritize efforts to engage this population fully. Caregivers frequently bear the responsibility of bridging these gaps, but reliance on informal networks highlights a systemic failure rather than a sustainable solution, as access remains contingent on personal resources and advocacy rather than universal policy. The cumulative effect of these assumptions and institutional practices is a healthcare system in which adults with learning disabilities are less likely to receive life-saving preventive care. Equity is compromised not through intentional denial of service, but through structural and cultural norms that deprioritize the needs of a vulnerable population. Addressing this inequity requires more than technical adjustments. It demands a reevaluation of underlying assumptions, proactive adaptation of healthcare delivery, and an institutional commitment to inclusion. Only by challenging both explicit and implicit biases within the system can preventive care be made genuinely accessible, ensuring that adults with learning disabilities are afforded the same opportunities for early detection and intervention as the wider population. Ensuring equitable access to cancer screenings for adults with learning disabilities requires deliberate, inclusive strategies that address both systemic and individual barriers. True equity in healthcare cannot be achieved through standardized procedures alone. It necessitates modifications that recognize diverse cognitive, communicative, and social needs. Accessibility must extend beyond physical presence in a clinic to encompass the entire process, from receiving understandable information to navigating appointments, undergoing procedures, and receiving follow-up care. Easy-to-read materials, visual aids, and simplified explanations are essential tools to communicate the importance of screenings in a manner that is comprehensible and actionable for individuals with learning disabilities. Such adaptations empower patients to engage meaningfully with their healthcare and make informed choices regarding their well-being. Professional training represents another crucial component in fostering inclusive healthcare environments. Medical practitioners, nurses, and administrative staff must be equipped not only with technical knowledge, but also with the skills to interact with adults who may require additional support or reassurance. This includes understanding behavioral responses to medical procedures, adjusting communication styles, and providing patience and empathy during appointments. Healthcare teams must be prepared to offer flexible scheduling, extended consultation times, and a supportive presence to reduce anxiety and improve the likelihood of participation. Without these accommodations, the system continues to privilege patients who can navigate conventional procedures independently, leaving vulnerable populations at a significant disadvantage. Caregivers and support networks play a critical role in bridging gaps, but reliance on informal support cannot replace systemic inclusivity. Policies should formalize the involvement of caregivers in the screening process, ensuring they can assist effectively without assuming sole responsibility for overcoming structural barriers. Patient advocacy services, liaison officers, or specialized coordinators can provide consistent support, helping individuals understand appointments, prepare for procedures, and navigate follow-up care. Such measures not only increase participation rates, but also reinforce the principle that preventive health care is a right rather than a privilege contingent on personal resources or familial support. Finally, implementing inclusive practices benefits not only the individuals directly affected, but also the healthcare system as a whole. Early detection through accessible screening reduces the incidence of late-stage cancer diagnoses, leading to more effective treatments, better patient outcomes, and decreased long-term healthcare costs. By proactively designing services around the needs of adults with learning disabilities, the system demonstrates a commitment to equity, social responsibility, and ethical governance. Embedding inclusivity into every stage of preventive care ensures that no population is overlooked, that every citizen has the opportunity for early intervention, and that healthcare delivery aligns with both medical efficacy and social justice principles.